So I started working as a paramedic in 1997. And my first job was up in Northern Ontario in this small community called Ignace. It was a volunteer paramedic service. And then I came back down to York Region in 97 and started working for what's now South Lake Hospital. It used to be called York County Hospital. The York Region took over in 2000 as we downloaded everything. I was fortunate enough to become an ACP in 2001 with the region. And during my time there, I taught for the base hospital prior to it being CEPCP, and did a lot with the education department there. And then in 2008, I was lucky enough to start working at Ornge. When I started with Ornge, we went up to northeastern Ontario. I started working in Timmins, Moosonee, Sudbury, that part of the province, which was eye-opening for myself, growing up and working in southern Ontario in a very sort of urban, suburban area. So working in some of our smaller communities, working up in the First Nations communities, the remote flying communities was quite an experience, and I learned a lot from that. And then in 2012, I came down to Toronto to work on our 799 aircraft, and that's where I've been ever since. And working for Ornge Education Department and working for the Ornge Base Hospital. So you might see me occasionally on calls helping you out. So that's me.
We were just saying before we started how I always remember this story because you're well known to being the consummate professional. And on Christmas Day, you brought cookies and everything to Uxbridge Brace for the paramedics just to show that courtesy. So I always remember that. And what a good
Oh,
guy.
that's awesome. Well, thank you. I always have to support the local teams because I really appreciate, like though I don't do the pre-hospital work anymore, I really appreciate how challenging pre-hospital care has become over the years. And I want to support you guys. So yeah, happy to help.
So I think where this could all go is talking about Ornge and
Mhm.
just kind of connecting the pre-hospital world to Ornge. So I can
Mhm.
let Dale start with some questions talking about the Ornge experience and as well as the pre-hospital experience.
I think, John, you made a cool point there about working in Northern Ontario, which I imagine is probably the transition for most people who are headed to Ornge that they will experience likely sometime in the north. How do you find that changes your practice? Because I find we talk to a lot of people who either work in Northern Ontario or who have worked in Northern Ontario. And one of the biggest complaints is that our medical directives are written with a very Southern Ontario lens. So I imagine that experience probably changed your practice a ton. I wonder if you could talk a little bit about what that looks like, or kind of that mind shift or mindset change from working in that area.
Yeah, it is very different. And I do agree. Like the medical directives in this province are written around an urban environment, are designed for shorter transport times, and I don't think they really give consideration to our colleagues in the north. When I started working in Ignace, our closest hospital was an hour and a half away from the town, and if we responded to any calls that were north or sort of southeast of the town, my response times were even longer, or my transport times were even longer. So when I have a VSA and I'm driving at least an hour and a half with a VSA, and at that time we didn't have TOR, right? So it was your 3 analysis and you go. And so for an hour and a half, I'm in the back with the firefighter doing CPR. Okay. um, Even other directives whether it's a cardiac ACS directive, pain management, all of these directives would require patching for ongoing orders, right? Because they're really set up for sort of that half hour transport time. So I think there could be some consideration from that regard, and I'm sure the base hospitals in the north have worked with their teams to sort of deal with those challenges, but something to consider. Because even in the south, and when I say southern Ontario, I'm thinking like south of Sudbury. Uh, I'm pretty sure even in your catchment area, like the Halliburton teams and whatnot, if they're doing a response that's sort of more remote, going to a cottage, going onto an island, going back into the trails to go retrieve somebody, you could spend a long time with a patient. It wasn't uncommon for me in Northern Ontario to spend, whether it was with Ornge or with my previous pre-hospital system, it wasn't uncommon for me to spend anywhere from an hour and a half, 2 hours, up to 4 hours or longer with a patient. And I had no medical directive that provided me guidance for that period of time. So constantly patching and asking for ongoing orders. But that could happen even in Southern Ontario. You have a prolonged extrication, you have somebody who is back in the bush or on an island, you're going to be with them for a very long time. So you need to have either discuss or practice the logistics around managing a patient for that period of time. Because it's not just about, at that point, getting to the hospital. It's about the logistics of stabilizing and maintaining their warmth and comfort for that period of time. Because they may just be sitting on a rock, or you're carrying them out on a scoop or number 9 or whatever tool you have, the Stokes basket with the fire department. How do you manage that patient for that period of time? And think about the logistics. Your D-tank only lasts so long, right? You only have so much fentanyl in your kit. So these are all logistics you have to think about.
From what you're saying there, do you think that's very valuable experience you had to be able to stay with these patients for that long and see the logistics and the constraints and how they actually responded to treatment or not? Like, did that help your practice subsequently?
Absolutely. Because again, working in New York region, transport times are very short, right? If I'm doing a call in Newmarket, the hospital's in Newmarket, right? Not very easy transport time. Even if I was outside the city, you're looking at a half hour maybe with the patient. When I went to Northern Ontario, so let's talk about my time in Timmins. I might fly an hour and a half, 2 hours to a community to retrieve somebody, spend an hour in the hospital resuscitating that patient, stabilizing them for transport. And then sometimes I would take the patient all the way down to Kingston. So I might be up in Hudson Bay, James Bay, but the receiving center that was, communicated through Criticall and agreed upon might be Kingston, or might be Toronto, or might be London, because they're offering the patient the care they need. That's the most appropriate facility for that patient. And so now you're talking about a 2.5, 3 hour flight, not to mention the drive in and out on either end. So I'm spending 4 or 5 hours with that patient. So in that time, I see the patient either improve with the management plan that's in place, or I might see that patient continue to deteriorate despite all of our efforts. But as a paramedic, that was an incredible experience for me, because now I'm actually seeing the benefits of the treatment I've been providing. All the things I've done up to that point, whether it's symptom relief or whatever I had done as an ACP, sometimes you get a sort of a quick response to your management. You provide a drug, you see the response, you get the satisfaction of knowing that helped the patient. But sometimes the therapies we provide, the medications we provide, there's more of a long-term benefit that we never appreciate as paramedics and never get to see, because it's tough to follow up with patients after the fact. But when you spend 5-6 hours with the patient, sometimes you get to see those benefits. A good example is managing somebody with elevated ICP. If you do all the things you're supposed to do to manage elevated ICP, hopefully you see an improvement in the patient's condition. ACS or a CHF patient, if you manage them appropriately, hopefully in the time that you're with them, you can see some improvement. And so being with somebody for hours on end, you do have the benefit of seeing that. And so even in the pre-hospital world up north, you might see those benefits because you're with a patient for an hour and a half, 2 hours, taking them to your local hospital from where they are. So I think that's great. The ability to spend time with the patient and watch their progression and learn from that has made me such a better medic. And the logistics around being with the patient in a out of hospital environment for that period of time really makes you think and plan about the considerations for that. So I can't leave a sending facility without making sure I have enough medication, enough fluids, enough oxygen. There's a number of things I have to consider before I leave the safety of that sending facility. Because whether I'm in a truck driving down a rural road, or I'm in a helicopter or a plane, there's nobody there to help me. The help might be an hour, 2 hours away, the next closest hospital. There's no turning back, or I could turn back, but I'm trying to get the patient to the care they need, the most appropriate hospital. So these are all things you need to consider before you leave with the patient.
You're not getting a rendezvous in the sky.
No, you're not. No. And if the patient deteriorates, you can't just land anywhere and hope for the best. Yeah. So, whether you're in a truck, a plane, a helicopter, you can land somewhere en route to your destination, but it doesn't mean that's the most appropriate place for the patient. And then you can imagine if you land at an airport in a community that just happens to have a community hospital, just because you need help, the the local paramedic service is not prepared to pick you up, so they have to free a truck to come pick you up. The local hospital are not prepared to assist you. And I could just hear the comments going, why is Ornge coming here with the patient? Well, we're just coming to stabilize the patient to help them get where they need to go. So it's not that it doesn't happen. It rarely happens, but sometimes it does happen. And these are the logistics you have to consider when you have a patient over a long journey and for the length of time we spend with them up in the north.
Absolutely. I'd like to take a deep dive into the clinical piece, but I think your perspective would be interesting on probably that task switching or role switching with Ornge, where sometimes you're leaving a sending facility, you're spending, an excessive amount of time with the patient in a stabilization role versus that on scene that probably feels a little bit more like the pre-hospital environment where, you're doing the on scene, you're headed to the trauma center. Is that ever challenging for you to try to task switch like that? Because I'm sure you're doing both things in one shift. And I
Yeah.
imagine those roles, I would assume those roles probably feel different.
Yeah, they're very different. The sort of scene call, traumatic scene call, is very unique to our rotor environment. Our trucks and our planes don't do scene calls, but we're starting to see a bit of a shift because we want to provide the best care we can for the province of Ontario and patients in Ontario. So there is a bit of a shift where our trucks are starting to do modified scene responses. Our trucks sometimes make it to a scene. If you have a prolonged extrication, we'll send a critical care team to the scene, whoever's available. And even our planes, we have had some sort of MCI events or, serious entrapments where the plane has made it to a community airport and then hopped in a local paramedic vehicle, gone to the scene, managed the patient, and then transported them. And though that wasn't technically a scene call, kind of was, being done with our fixed wing aircraft. So in the province, I think when people think about calling Ornge for a scene, it's very much in the regions where there is access to a helicopter. But people need to think about what's best for the patient's journey, right? And so it doesn't matter where you are in the province, and it doesn't matter what the patient's condition is. I know we focus on trauma when it comes to scene calls, but we do medical scene calls. Our Sudbury helicopter does a lot of medical scene calls where the patient is in a remote location. The local ambulance is going to take an hour and a half just to access that patient, or maybe they can't access them because they're on an island. And so our helicopters sometimes do medical scene calls. And yeah, there is a bit of a mind shift between an interfacility call and a scene call. Scene call is you technically, you think about, much like in the pre-hospital world, load and go with the patient. Like, we need to get this patient to a hospital. The thing is, though, even in those environments, and even with the traumas, you get a critically unwell trauma patient. People think about that golden hour still. People think about, we got to get this patient to a trauma center as soon as possible so they get definitive care. The part that we forget is that as a critical care paramedic, I have some tools and some treatments I can offer that patient on the scene that can stabilize them, resuscitate them, secure their airway, and make the transport of that patient to the trauma center much safer for the patient. And I can actually reverse some of the problems that we're encountering, right? So if I show up on a scene, just like if I show up in a hospital and I have a critically unstable patient, I'm having a hard time getting a blood pressure, they're not perfusing, maybe their airway is not patent, it's not being managed with BLS maneuvers. I have some decisions to make. Do I throw that patient in the back of the ambulance, doesn't matter what asset it is, and just quickly go to the appropriate hospital and hope things go well, hope they don't lose their airway, hope they don't vomit, hope they don't arrest because they can't get a blood pressure on them? Or do I take the time to obtain access, provide them the care they need, whether it's fluids, blood products, pressors, and actually perfuse their organs, perfuse their brain? And then do I make a decision, do I provide a definitive airway at this point? So now that I have them resuscitated and they're perfusing, is it now safe for me to intubate this patient for transport? And that allows me to provide them better oxygenation, appropriate ventilation, a lung protective vent strategy. And in the case of somebody with like a TBI or a bleed, There are a number of parameters you want to hit to help them with their brain recovery. And you can't do that if they're not perfusing their brain, number one. And if you haven't secured their airway and you can't oxygenate and ventilate them, that's not helpful for that patient. So now do I throw them in the back of my truck and drive an hour with this unstable patient who might arrest, who can't protect their airway, who's not oxygenating well? Or do I take the time to do those things and ensure that when I now go for that 1 hour drive or 1 hour flight, I have a patient who's well perfused, oxygenating, ventilating, and I can take them there with the best possible outcome for that patient. I think that's how I approach patient care. So there are patients where you just need to load and go. For us in our environment, those are the surgical emergencies, right? You have a ruptured AAA. I can't do anything for you. You need a surgeon. So what I do is I grab all the blood I can, throw you on my stretcher, and we go and hope for the best. They're usually too unstable to intubate because I can't get a blood pressure on them. I know they're perfusing their brain because they're talking to me. That's it. Off we go. So those surgical emergencies like that, that's the one time where I truly load and go. Everybody else, yes, there's a time sensitivity piece to it. And I do, in the back of my mind, think about time on scene. But with our training and our ongoing practice and our team approach, our standardization of our bags and our approach to managing a patient and our approach to resuscitation, if I respond to a traumatic on scene, and when I get there, the patient's not trapped, you have them extricated, they're on your stretcher, in about 20 minutes, I'm able to resuscitate that patient, so obtain appropriate access, whether it's IVs, IOs, initiate resuscitation with fluids and blood, pressors if necessary, secure their airway using an RSI, and then package them for transport. I can do all that in 20 minutes, half hour tops. But now I'm transporting a patient who I know has a much better probability of surviving this event. And I think that's important to consider. What's best for this patient? And sometimes not just throwing them on a stretcher and departing the scene is what's best for that patient.
There's so many key points in there. And I was just thinking when you're explaining that, thinking how nuanced this all is, especially it's all dependent on what we do. Like imagine you get an update, this is the patient, this is what we've done, this is the fluid we've given, this is the medication we've given. That all dictates your subsequent care too.
It does. Yeah. And the more care you can provide, and I know your medical directives are expanding. So the more care you can provide prior to us getting there is only beneficial for the patient. The more information you can provide us while we're responding only helps us better prepare for a route to walk into, right? So when we receive the call, we are already planning what our approach to this patient might look like. So part of our success and our ability to provide all these interventions I discussed in that timely manner, like being on a scene for only 20 minutes, but providing all that care, that comes from our planning, our ability to plan en route, prepare meds en route based on the information you provided us. Even if we don't know what's happening, if the information we get is just a 911 detail saying it's a head-on crash, people are trapped, possibly unconscious, I'm preparing for the worst, right? So I'm talking with my team. We are having discussion about what resuscitation is going to look like, what airway management is going to look like, what our priorities are on that scene. And then when we show up on that scene, we're now executing the plan that we've already discussed, right? We're not making it up as we go, because that's just fraught with failure for sure. But the more information you can provide us helps us understand what the next steps are, and we can adjust the plan accordingly. But even if we show up on scene and you provide us an excellent report, like we don't have the information ahead of time, we show up on scene, we provide an excellent report, then we can make decisions and move on. But the more you can get started, IV access, IO access, TXA, pain management, all those things you can do ahead of time before we get there are helpful to keeping our on-scene time shorter, providing the patient the care they require, and us getting them to the most appropriate center in a timely manner. So we can all work together as one big team to think about the patient and put the patient first, and then get them to the most appropriate facility for that patient. And I keep saying the most appropriate facility because we focus on trauma when we talk about Ornge and helicopter response, but this could be a medical scene call. You might be calling us because the patient is in a remote area and they're having a STEMI, or you recognize they might be having a hemorrhagic stroke that sort of thing. So thinking about the most appropriate center for that patient, whether it's a cardiac center, a stroke center, whatever, there are lots of things we can do to help that patient with their journey, improve their outcomes with the care we provide. And we're going to work as a team to do that.
I love that you said that you talk with your colleagues about, okay, this is the information we have at this point. Let's execute and develop a plan. And this is what we're going to discuss, that very high performance kind of attitude and perspective to it. Because just from my personal opinion and anecdotally, I don't know how often pre-hospital providers do that, especially if you're working with a brand new person, it's not your regular partner, and we probably should. And if we look at the aspect, should pre-hospital paramedics train more of Ornge for that collaboration? Like, would that dramatically improve patient outcomes? What do you think if we could just wave a magic wand? Do you think that would optimize patient outcomes if we did that?
I think it would. And I don't think it's nothing specific to Ornge. I think our philosophies that we've implemented at Ornge, that's what needs to be shared with everybody. And I know some services, like some education teams at some services and some base hospitals, are trying to incorporate that and teach that. You see it and hear it in the field. But I think if we demonstrate an organization, now you like speak to Ornge, an organization that's sort of embraced that approach, right? We've embraced that philosophy of good team dynamics, whether it's our team, your team, us all working together as an ad hoc team, working, because we work with a variety of paramedic services, first response teams, various community hospitals and nursing stations where the level of care is different and the number of providers are different and their experiences are different. And so part of that ad hoc team working well together is us coming in with a sort of a solid plan, so we don't have to worry about or discuss too much what our approach is, but we can now work with that team that's on scene, support them, get buy-in from them to help us help this patient. That's really the philosophy of this. And where this all comes from, because I can speak to this, we changed our approach to CCP training a few years back. And one of the big changes that we made to our CCP training is this very thing we're talking about team dynamics. So our CCP training has always been, it's incredible. Like, and I must say, like, I was very fortunate to come to Ornge and learn from some very senior, experienced critical care medics, some very senior, experienced physicians, RTs. Like, there are a phenomenal group of people that provided me education. And so the medical training has never been an issue. It's always been top notch. But when I started getting involved with the critical care education, one of the things I would see is we put these people through these very challenging simulations that are very realistic, like going into an ICU or an emerge and dealing with a critically unwell patient that has multiple things going on. You have to sort out what's happening, get buy-in from the team, and then come up with a plan and execute it. And the part that kept preventing the team from succeeding was not their understanding of what was happening, was not their medical management. It was their ability to organize and work together. You would have multiple people doing the same thing. You know, if the airway needs to be managed, you have 3 medics trying to manage the airway together, but nobody's taking the leadership role. Nobody's coming up with a clear plan. Nobody's assigning roles. People aren't accepting the roles they've been assigned because they see an opportunity to help and they want to get in there and do something, right? People will get tunnel visioned on doing a skill, but there's also supposed to be the team leader and have good oversight and overview of the room, but they lose that because they're focused on the skill, which is fair. That's what happens. The team as a whole getting tunnel visioned on the one problem. So let's say that the patient has a difficult airway. All the paramedics that are in that simulation on that team are all focused on that airway, and they maybe aren't paying attention to all the other things that are going wrong. The patient's hemodynamically unstable, their blood pressure's dropping, they're now throwing PVCs and going into an arrhythmia. That all gets missed because they're all tunnel vision on the airway. So it is the idea of how do we work better as a team? How do we work with our colleagues, whether it's pre-hospital, in-hospital, these ad hoc teams? How do we get buy-in from them to work with us? And then it's the cognitive offload. Like, how do we make sure that when you're in these really high stress, high stakes cases, that you can perform and keep moving forward and not get stuck? Because that sometimes happens, right? There's many reasons that happens. So this is what we saw happening in our simulations, that we try to make them as realistic as possible. And then when we do that, we see these behaviors show themselves. So then we started looking into the whole team dynamic aspect of things, and there's all kinds of information out there on this. One of my favorite people to listen to is Cliff Reed, and he does a lot of excellent presentations on team dynamics and what they do down at Sydney Hems. And we started incorporating some of those things. So some of the things like the 0-point survey, right? That's the whole step up mnemonic. When you're responding to a call, thinking about yourself. Am I in a good mind space or a good head frame of mind as I'm responding to this call? Did I get enough sleep last night? Am I fatigued? Am I hungry? Those sorts of things. We need to take care of ourselves. And if I'm having some challenges that day or that call, like maybe we haven't had lunch yet and I am starving and my sugar levels are dropping, I'm not thinking straight. It's important for you to tell your partner, hey, I'm not feeling so great right now. So your partner can take the opportunity to go, okay, you know what? I got you. I'm going to step up and support you. So I'll take the lead on this, or make sure we double check all our math, because I know you're not in a good space right now. Your team, making sure your team is in a good space. So I'm checking in with my partner saying, hey, here's some water. Let's make sure we drink and hydrate. Here's a snack. Let's make sure we have a little snack. Sounds like this call is going to go on for a while. That sort of thing. Make sure your team is in a good space. And it could be any kind of challenge, right? Maybe something's happening at home and your partner is very focused on something that's happening at home. So appreciate that, declare it, say, hey, I'm really not in the right mind space today. I'm thinking about my kids at home. Something's happening. No problem. I will take the lead on this call. Let's just work this out. Thinking about your environment, right? So are you responding to, like for us, are we going into a community hospital as a patient in a recess room? I have lots of help. It's well lit. It's warm. Lots of space to work. Or am I going into a townhome that I respond to all the time? And I know these townhomes are difficult to walk up because they're 3 stories and there's tiny bathrooms and the patient's in the bathroom. Think about those things. Think about your environment. Think about how you can optimize your environment, right? Think about the patient. This is all part of the preparation, right? Based on the details we have, what are our possible differentials for this patient? Let's talk about that. So when we walk in, we're not surprised, because we've already had a discussion about all the possible differentials as to what could be going on with this patient. And yeah, it might throw the odd curveball at us, but we're still better off preparing, right? Even if you had a situation, let's say you were responding to a trauma and you're told, okay, it's pedestrian struck. And the dispatch information is that you're going for a 40-year-old pedestrian struck. Okay, great. So you and your partner are responding to this call. You have 10 minutes to figure out what's going on. And so you're talking about all your possible differentials. So pedestrian struck, they could be TBI. So I'm thinking about all that TBI stuff. They could have chest trauma. They could have abdominal trauma. They could have pelvic trauma. Maybe they have a fractured femur. So we go through all the possibilities and what we're going to do for those things. We talk about getting IV access, providing fluids, providing TXA, what are we going to do for analgesia, what are we going to do for airway management. So we have this discussion. So then we show up on scene, and guess what? It's not a 40-year-old. It's a 4-year-old. Well, what am I going to do? Am I going to freeze at that point? No. You know what? We already came up with an excellent plan on how to manage a patient with multi-system trauma. I just need to adjust my expectations as far as age and weight. So now I'm going to measure them, see what their weight is, and go, okay, for this 4-year-old, we're not going to give 2 liters of crystalloid. We're going to give 20 mils per kilo. I'm not going to put a number 8 tube in them. If I have to intubate them, I'm going to provide a tube that's appropriate for their size. The approach to managing the patients is exactly the same. I just need to make some adjustments based on their size. But we're already in a much better mindset walking into that call because we've discussed the plan for a multi-system trauma patient. So those sorts of discussions really do help, even if you're a little surprised when you show up on scene. So that's the patient piece of the step-up survey. And then the up part is just the updates and then your plan going forward. So one of the good things to do as a team is always sort of pause and have rally points and have sort of that closed loop communication, right? So if I ask you to perform a task, so if I'm working with your medics on a scene and I'm like, hey, can you please establish another IO or another IV? Part of that closed loop communication is you then telling me, hey, I've established another IV for you. It's patent, it's working well. I go, great. Now I can check that off my list, or I might assign you another task. But if the scene is very, very busy, why not have built-in rally points? We go, okay, we've been on the scene for 5 minutes. Let's stop and see where we're at. And everybody gives an update as to where they're at. And then we talk about next steps, and then we execute the next steps. So those are the kind of things we do. And once we implemented that and taught our team that approach, which is nothing new, that's an approach that's been out there for a while, we dramatically saw an improvement in their management of patients. So it had nothing to do with the medical management. They were doing a great job at the medical management. It was the team dynamics. And I can tell you time and time again, where whether it's in hospital situation or a pre-hospital situation, where calls do not go well is that team dynamic piece. Because the patient is the patient. They're going to progress one way or the other. We might be able to stabilize them and prevent things from deteriorating, or they might just deteriorate no matter what we do. So if we focus on that, we may win, we may not win that battle. But if I focus on working with the team and making sure that we do everything necessary to support this patient, and like I said, it could be anything. It could be, we need more support. Like maybe we need more crews on scene to help us with the logistics of extricating this patient. Maybe it's having to work with other allied agencies. So I'm working with your paramedics, but we also have to work with the fire department and figure out what's the best way to extricate this patient from this vehicle without causing more harm to the patient, right? So sometimes you just need to stop, get everybody together, figure out what the best thing is for that patient, and then work as a team to achieve that goal. And part of working at Ornge is we work with so many different teams. So I mentioned the pre-hospital teams, whether it's the paramedics, the fire department, the police officers, in hospital, whether it's a nursing station, it could be a small community hospital. It might be like a medium-sized or larger hospital where they have lots of excellent physicians and nurses and resources, but the patient still needs to go to a specialized center. All of those teams have different goals and different mindsets. And so I've learned over the years how to adjust and integrate into those teams and work with them. But that is what makes the biggest impact on whether or not a call goes well or not. It's not the patient care, because everyone provides really good patient care. It's the team part of it. So yeah, that's where you have the biggest impact, honestly.
This podcast is for educational and informational purposes only. It is not medical advice, does not establish a standard of care, and must not be used to diagnose, treat, or manage any medical condition or emergency. The content discussed reflects general principles that may not apply to every situation, system, or patient. Clinical practice varies by region, service, and jurisdiction. Always follow your local medical directives, clinical guidelines, protocols, and the instruction of your medical oversight or base hospital physician.